welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. Hello, friends. Happy Monday and welcome to Brain Chat. It's Dr. Mitzi, your board certified neurologist and MS doc. And I am so excited to join you all on another Monday for Brain Chat. We've got an extremely special guest that I'm super excited about. And you guys know how we do at the beginning of the show. Log into the chat. Tell me where you are logging in from, where you are viewing from. I love to know who's watching the show and where you're watching from. And I thank you so much for taking a little bit of time on your Monday night to spend some time with us. So we want to first start off by thanking our sponsors. You can visit more2ms.com to learn more information about one of our sponsors, Janssen. And we're so excited to be talking about family planning tonight. So May is Women's Health Month. And I think that, family planning is a large part of that. Certainly is not all that our women are concerned about, but something that we definitely want to discuss here on Brain Chat. So I am super excited to have an amazing guest with me tonight from California. So we're on opposite sides of the country, but we will be chatting it up on the Brain Chat Facebook Live and podcast today. So let me tell you a little bit about Dr. Bove. All right. I see somebody logging in from Little Rock, Arkansas, Massachusetts. Hey, I'm going to be headed that way later this week because Dr. Mitzi's on the road again. I think it's Kenny Loggins or Kenny Rogers. One of the Kennys sang that song, On the Road Again. All right. So here we go. Let's talk about Dr. Bove. So she is an associate professor of neurology at UCSF, and she is the director of digital innovation in the UCSF MS group. She sees patients there. She obtained her BA from Harvard and her MD and MMSC degrees from Harvard University. She did internship, residency, and neuroimmunology fellowship at Mass General Brigham. And her research is on sex and gender-informed neurology, and it has been funded by the NIH, the National MS Society, the California Initiative to Advance Precision Medicine, Hilton Foundation, and from industry partners. She has done Fulbright work on social determinants of health of women and children in West Africa. And her current clinical research is on caring for MS during pregnancy and the menopausal transition. She has also done research focused on gaps in women's health and promoting sex and gender-informed neurology. I am so super excited to have Dr. Bove with me, and I am going to bring her into the stream. Hi there, Dr. Bove.
Hi, Dr. Williams. How are you? Hi, everybody.
Hi, everybody. And I'm doing great here. So in Georgia, it's a little later than it is in California, but I understand you've had a long day too. So, the days can be long, even if we're on opposite sides of the country. So anyway, thank you so much for joining us. And with everyone that comes to Brain Chat, I love to just kind of first start off by asking you to tell us a little bit about yourself and how you got into the field of MS.
Yeah, great question. So there's a couple things that I just love about taking care of people with MS and also doing research on MS. And one is I just think the brain is fascinating and people are fascinating. And I just love the personality aspect of neurology. I've always found brain health much more exciting to think about than kidney health or skin health. And then when I was thinking about MS specifically, I love the fact that we can really make a difference with medication. We can make a difference with whole person care and with lifestyle, and we can really be engaged in people's lives for a very long time. And those are things I really love. And specifically, MS affects 3 times more females than males, and there's a lot of hormonal regulation. So that's just so fun to think about, and to sort of think about how to guide people during all of their reproductive transitions. So just a lot going on there.
Yeah, amazing, amazing. And that's also one of the reasons that I loved MS, was that longevity that I get with my patients. So when somebody asks me, "Hey, Dr. Mitzi, Miss Jones called. Do you know Miss Jones?" I'm like, I know Miss Jones. I know her mama. I know her kids. I know her grandma. I know her spouse. And so I love that I get that engagement, but also that we get to take care of the whole person. Because we do spend a lot of time with people, especially very early on in the journey, and when they're in periods of transition. And most of our patients are women. So it also helps that many people feel like they can relate to me as a woman, and maybe tell me some things they might not tell their male doctor sometimes. So that part is kind of cool too. All right. So let's get into talking about family planning. So I really wanted to address this during Women's Health Month because there often are a lot of questions around family planning. And I wanted to start with kind of a bit of a historical perspective. So some of my patients who are a little older or a little more mature, as I like to say, will come in and say, well, when I was young and I got diagnosed with MS, they told me not to have kids. So let's talk a little bit about that historical aspect and how that has changed over time.
Great. And it is fun that it's during Women's Health Month and also the day after Mother's Day. And so just really thinking about how to support the people who want to be mothers and so forth. So yeah, it's a great historical transition, Dr. Williams, because I think for a long time, truthfully, a lot of the neurologists were men. And there was not a lot of good research into women's health. And so the sort of most kind of cautious approach was just to steer clear of it altogether and just advise patients to not have children, that, they shouldn't have kids that they may not be able to fully care for, and all these kinds of things. And what we've seen over time is that many of our patients can do very, very well. And many of our patients want to have a family, although not all. And actually, we can use medicine and good advice to help our patients achieve the goals that they have, the goals that they set out to achieve. And so I think the field has really changed, where we're actually working on, doing the research to actually support the advice that we give, not just steering clear, but actually doing the work and trying to answer the questions and listening to our patients and what their goals are and what their questions are, so that we can do better research. And then, finally, advising people today that it's really about their fertility goals, their childbearing goals, and what is possible from a fertility standpoint. And our job as the MS neurologist is just to support those goals and help sort of optimize stability around those goals. So I think the field, as you said, has changed a lot in the last decade or two.
Absolutely. So important. You said so many keywords in there: support women, right? And listen to our patients and support their goals. I think there also has been really a transition in the neurology community, with this advent of shared decision making, which should be the way that we treat our patients all the time. And for those of you that don't know what shared decision making is, it means that you're an active part of your healthcare team. As a person living with a condition, you bring your knowledge of your body and your, living situation and goals to the table. The physician brings their knowledge and the goals to the table, and we work together to try to come up with the best plan that is for you. And that plan may look different than someone else's plan. And so I think that, this is a key component when trying to, talk about subjects like family planning, is that shared decision making. What are your goals? And so for my patients who are of childbearing age, that's a common question that I ask them. Are you thinking about having babies? Or they may bring it to the table. I'm thinking about having kids. And I think that now with reproductive technology that's changed so much, some of my patients who used to be considered kind of older and not wanting to have kids are still wanting to have kids, or they're going through things like freezing their eggs, right, in preparation. So there's so many different things people can do now, and it's so amazing. So let's kind of talk about what that conversation looks like, right? When someone comes into the office and says, I want to have a baby, or I'm ready to have a baby. What does that conversation look like, between you and your patients, when they kind of
Yeah.
talk about that
Yeah.
subject with you?
I think one key thing is that when they're ready to have a baby, that's probably not the first time we've broached the topic. And
Mhm.
so it's really important, and I know you and I have talked about this, before, but it's really important that we're actually assessing a person's goals every time we see them, so
Mhm.
that it doesn't come as a surprise when there's the day that they actually are ready to start a family. And so a lot of times we'll sort of broach the conversation: is there an interest in the future? What's the time frame? Is there a partner involved? What are their concerns or preferences? Kind of laying a little bit of the groundwork. And sometimes people will say, no, 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 and no, and I'm not interested. And then the next visit, they might be like, now I am, or
Right.
there's
They
more
definitely, you can
chances.
change your mind.
They met the right person. They had or they decided that it's not for them, But so I think really one key thing is that we lay the groundwork and start some of the just counseling and conversation around this the first time we start talking about treatments, when we talk about a person's life goals, and then we revisit it. It can be a sentence, it can be a conversation at every visit, so that when a patient is ready to start thinking about childbearing, or as you mentioned, sort of, either IVF or egg freezing, or maybe IUI if they're in a partnership with a woman, or whatever the decision making is, when they're ready, it's not sort of a surprise, and we have sort of phased a little bit. So then, the approach is always one of thinking about, what their goals are primarily, what their fears are, and then thinking about specifically, two things. How can we optimize the window of actually getting pregnant? How can we optimize the likelihood of getting pregnant in the window that we have off therapy? That's one big piece. So if we need to think about, are you going to need any fertility help, et cetera, we do some of that groundwork ahead of time. And then also thinking about how do we optimize the safety of the sort of pregnancy. Do we need to stop the medicine? If so, what's the time frame, or can we continue it? So I think those are two things. How do we optimize the fertility? And then what do we do about the medicine, as sort of the two real kind of shared decision-making pieces.
Right. And so, you said so much that was important there. And I think that's why one of the things that I think was most important in the title was family planning. So the first thing, I ask people about their interest, but I'm like, listen, if we want to get pregnant, we need to plan. Now, we can't prevent everything, right? And we know that many pregnancies are unplanned, but certainly with many of our medications, we counsel people, you need to be on birth control. If you're ready to have a baby, let's talk about it from the beginning. Let's try to plan it out to the best of our ability. And then we also have to have these contingency plans, because everybody doesn't just come off their birth control and get pregnant the next day. Sometimes it takes a while, so the piece that you said about thinking about fertility, if there are issues there, kind of working those things up ahead of time, so that we can see what we need to do about medications, will make a big difference in how someone does. Now, traditionally, when I first started practicing, if somebody said the word pregnancy, we took them off the other medications and we just kind of said, let's see how it goes and we'll check in every couple months. How has that thinking changed? I know there's been some literature that's been produced. I know that you and others are doing work focused on pregnancy, focused on breastfeeding. We have lots of registries now with our disease modifying therapies that tell us about outcomes. So tell us how that thinking has changed and kind of some of the general approaches that we look at with medications
Yeah.
during pregnancy, up until conception, or, just whether we stop completely.
Yeah. So I think it's changed a lot for a couple of reasons. One is that we've realized that there's a huge mismatch between what the label says and what makes sense biologically. So, that classic example, is the monoclonal medicines where the label will say, do not conceive for 6 months or 12 months after an infusion, but we know that they're really out of a person's system much, much sooner. So one thing that's changed is just like the labels don't make biological sense.
Right.
The labels are sort of CYA careful, but they're
Right.
not really, informed. The second thing that's
CYA
changed.
for cover your assets.
Thank you. The next thing that's changed is I think there's been a lot of people who have, as you mentioned, maybe gotten pregnant without intending to, or maybe said, I'm just going to go based on what makes sense biologically and not the label. And so there's a lot of what we call real world evidence, where it's just people in the real world doing what they do. And then we study that and figure out, oh, well, maybe the safety isn't so, scary, or whoa, maybe there is a concern. And so we really look at what people do after a medication has entered the real world and kind of see what the safety, profile is there. And then the third thing that we've done is when we took people off some medicines, we saw that actually they rebounded. And so the specific medicines are Gilenya and the medicines like Gilenya and Tisabri. And we saw that when we took people off the medicine, their immune system, it was sort of like the cat's away and the mice come out to play. The immune system, you took the medicine away and the immune system really reactivated, and sometimes really dramatically and severely. And so we realized that just taking people willy-nilly off their meds is not always the best decision. And so I think with those three kind of big picture pieces, we've become a lot more thoughtful about what we do. And so sometimes we're actually, sort of going with a patient's preference to have zero drug on board whatsoever at the time that they conceive. And other times we're thinking, okay, well, maybe this patient could really relapse if we took them off their medicine, or if they were waiting a long time to get pregnant. And so maybe we'll keep them on something for as long as we can. And so all of those kind of big picture pieces go into the individual decision making. And from an individual decision making standpoint, maybe we can keep some of our patients on those first line self-injectable therapies like the Copaxones, the interferons, up until pregnancy or even through pregnancy. Maybe we can keep the patients on the infusion medicines, up until pregnancy or sometimes during pregnancy. And maybe we still need to be really careful about the oral therapies. Is kind of what we're thinking. Each time we're balancing a patient's risk of MS activation and also their preferences around, what exposure they would tolerate. So I think those are the general guidelines, but we can also get specific,
Yeah, we can get into the weeds. But there, again, there's so many things, and we keep coming back to that shared decision making, right? So that coming up with that plan that's specific for that person, but I think that one of the key takeaways is that this advent of what we call real world evidence, looking at how medicines perform in the real world, looking at what happens to people in the real world, world, has really helped us to inform our decisions better when counseling our patients, because obviously you can't do research trials on pregnant women, right? That's not really ethical to take people off or put them on and off their medicine, right? But you can see what happens once something is in the real world, and then use that information to determine, what's the best course of action for that particular person. So, in thinking about just kind of taking a step back, looking generally at pregnancy, I've had a lot of patients that have asked me, Dr. Mitzi, do I have a high risk pregnancy because I have MS? How would you answer that question?
That's a great question. There's a couple things about the pregnancy piece and a couple things about the MS piece. So the MS piece, during pregnancy, in general, MS quiets down, and people will be familiar with a pregnancy effect on different autoimmune diseases. So, rheumatoid arthritis quiets down, lupus acts up. So we have to be kind of thinking about what does the condition do itself. So during pregnancy, MS kind of quiets down a little bit, and then it activates a little bit postpartum. So during
if you don't mind me asking, why do we think it quiets down during pregnancy? Is it like an immunosuppressive effect, or do we know
it's a
why?
great question. The immune system has to change during pregnancy because the body has to tolerate a foreign organism, the fetus. Half of the DNA is from the mom who's sort of carrying the fetus, and half of it is from the other parent. And so, or the other, genetic contributor. And so the body has to tolerate DNA that's foreign. And in order to do that, the immune system has to shift. And so I think a good term is immunotolerant, because the immune system has to tolerate the fetal DNA. And to do that, you would see a lot of shifts in different aspects of the immune system. And historically, we said it was a T helper, subsets that change, but it's a lot more complicated than that. But in general, the immune system has to adapt. And so sometimes the way that it adapts works in favor of some autoimmune conditions, like they're like the lucky, kind of tag-alongs in the system. And sometimes it works not in the favor of the immune condition. And so each kind of ratio of the pro or the anti-inflammatory pieces is going to affect each different condition and each person somewhat differently. But so we do see that immunotolerant state in pregnancy in MS. And so we see in general, people have fewer relapses. And also, it looks like pregnancy does something good, not just to the risk of relapses, but also symptoms. Patients often say, and I bet they tell you the same thing, that they feel good during their pregnancy. They feel, sometimes they say, I feel like I don't have MS, or, just a little better.
Especially that second trimester, they often feel great.
Yeah. Not to say that there aren't other things, the fatigue or the sleep or the bladder, but that from the MS standpoint, sometimes they feel a little better. And then when the baby is delivered, then the immune system kind of like swings back like a pendulum the other way. And sometimes it can overshoot and be kind of extra active. And so that's when, we worry about the postpartum piece. And so I think, one thing is the MS shifts a little bit. And then the second thing is, does MS affect the pregnancy in general? We don't really see that in any big way that MS affects a person's ability to get pregnant. It may affect their mood or their libido, or kind of, their energy level, which are going to affect, sort of downstream, whether they're in the situation where they might get pregnant, but it doesn't necessarily affect their hormones in a major way, we don't think. And we don't really see that it affects sort of overall the likelihood of a pregnancy going to term, or the size of the baby. There may be a few sort of caveats to that, but mostly MS doesn't seem to affect the outcome of the actual pregnancy in any major way. So, people can get pregnant and can have, a healthy pregnancy. And so in general, if, if all things are going well, maybe it's not even considered a high risk pregnancy.
Mm-hmm.
We do see that women who have some more advanced MS, maybe they're doing a little worse, they seem to have a higher likelihood of having like an operative delivery, whether it's forceps or cesarean. And we're not sure if that's because they need it or because the doctors are being careful.
Mm-hmm.
I think that's the one thing we don't know a lot about women who have more, advanced disability. But in general, if there aren't sort of treatment, if there aren't questions about the MS therapy, sometimes people don't even need to see a high risk OB. At least that's kind of the general guidance. I don't know if that's kind of what you tell your patients as well.
Yeah, absolutely. Yeah. So, so I think the key takeaways here and things that I relay to my patients are that, as far as we know, and as far as the research suggests, just the fact that you have MS doesn't necessarily mean you'll have a complicated pregnancy. So, we're not talking about medications. We're not talking about side effects of medication. We're saying just because you have MS doesn't necessarily mean you're going to have poor outcomes. It should not affect your fertility, your ability to get pregnant, as you said. But certainly if people do have more disability, especially if you have weakness in your legs or spasticity or real tightness in your legs where you can't straighten them out, that could cause some issues with delivery itself. So I offer my patients pretty similar advice, to what you suggested. So, okay. So we talked about, kind of getting pregnant. We talked about a little bit about some of the medications with pregnancy. Let's talk a little bit about fertility. So we kind of touched on it a little bit, but now, so when I started practicing, fertility treatments were either extremely expensive, not covered by insurance, or not really an option for many of our patients. So we used to just take them off their medicines, have them try for a little bit. Sometimes we would take a break, go back on medicines. But now we have people who are getting hormones for fertility treatments where they need eggs harvested and things like that, or either they're getting, insemination, things like that. How does that affect, interruption of treatment or, the treatment cycle with MS?
Yeah, that's a great question. And it's one where we have like hot off the press kind of information that kind of can,
Ooh.
like change things a little bit. So, you know, as you well know, for about 5 studies in a row from different parts of the world suggested that women who are getting like active fertility treatment, so mostly IVF, experienced relapses during or after their cycles. And that really was quite concerning. And what we've seen since then in several studies, a small one that's published, but some other studies that have been recently presented at conferences and that are kind of trickling through to publication, is that if you take women today and you keep them on their medicine, they do fine. They don't have relapses. And so one of the key things is to think about safe and effective therapies for MS that we can keep patients on so that they can just get through their fertility treatment, as sort of efficiently and best they can. And then the other thing that we're figuring out a little bit is different fertility treatments mean different things. So you have like the full gamut of IVF where you're stimulating the ovaries, you're getting the eggs, and then you're fertilizing them in vitro, and then transferring the embryo back into the uterus. So that's kind of like the full IVF. But some people just do ovarian stimulation to kind of get the eggs going, and then they just sort of have sort of spontaneous, sort of like they conceive. Sort of without the IVF or the egg harvesting piece. Some people do egg harvesting for fertility preservation and don't transfer any embryos back into the uterus. And some people just do IUI, where you're just sort of inserting sperm without any hormonal treatment. And so it's a lot, the landscape has changed a lot. And then some people do embryo transfer from donor egg. And so, there you can have a couple of the menu options or kind of the full IVF. And so we're seeing that the picture is a little bit different according to what people do. And I think the take-home point is, again, we can work to support a patient's fertility treatment and fertility plan, and we can work around that with medicine. And so thinking about safe medicines, effective medicines that we can keep patients on during the process is probably the key to helping them get through it, and get through it with stable MS.
Okay. And which ones would you generally consider safe? Now we talked about the injectable medications, which we now have upwards of 20 years of data on those therapies. And we know that they're relatively safe during pregnancy. In some of the earlier studies, we thought that they may have caused spontaneous abortions. But many people can take those medications safely. So in this kind of new era of medications, which ones are relatively safe, or have been shown to be relatively safe from the data we have available?
Yeah. So the oral medicines, the pills, we're still proceed with a lot of caution. They may not be, so the Gilenya is sort of the one that has been associated with some congenital malformations and also with that rebound. If you stop it early on in pregnancy, you're risking a big relapse. The Obagio people are supposed to stay away from because of a risk of, true sort of teratogenicity. The Tecfidera and the Cladribine, the picture may be a little more mixed. So that's the orals. So then, as you mentioned, the self-injectables are considered quite safe to continue, certainly up to the point of, we would say conception or embryo transfer, right? Like when the baby's actually going to, the embryo is going to actually be transferred and then implant and then establish a blood supply. And that's when it could actually even see drug in the mom if it were to cross the placenta. So the self-injectables are considered safe, certainly to the point of embryo transfer, and maybe even up to the point of sort of placentation, or maybe all the way through pregnancy. They're not the most effective. They're safe, and they're some of our least effective therapies, right? So the other flip piece are the infusible medicines or the monoclonal antibodies. So there we're really thinking about Tisabri as a class, and we're thinking about the B-cell depleting medicines. Ocrevus, Rituxan, and Kesimpta follows suit, even though it's a self-injectable. It's not an IV medicine. And those monoclonal medicines are actually very effective, and they don't cross the placenta in the first trimester. And so it does give us a little wiggle room to figure out what's happening, certainly to help patients through the ovarian stimulation piece, and maybe to think about when to time them relative to the embryo transfer piece. So we have a lot of pieces to work with.
Yes, absolutely. And we have a lot more options to work with than we had, even 10 years ago. And I think, the key with all of this, especially with programs like this, is that we are not offering particular medical advice to anyone. But, the important thing is to go back to your team and talk to your team about what the best plan for you is. Each person does differently on different medications. There are some people who do really well on medicines that are considered less effective, and others that don't do well on ones that are considered more, but the bottom line is, we do have options. We do have data. It is not a thing where we are telling people absolutely don't get pregnant. As a matter of fact, I always give this caveat or this story of one patient I had who basically almost felt like she was treating her MS with pregnancy. So, the last time I saw her, she was on baby number 6. And I was like, really? And she was like, I'm like, well, if you can feed them, she would get pregnant, breastfeed, and then have another baby. Then she get pregnant again, breastfeed, then she get pregnant. So every time she comes to talk to me about medicine, either she was breastfeeding or she was pregnant again. So we don't recommend that as a treatment for MS. But, again, it goes to say that the thinking has really changed over time, where we do want people to achieve their goals, to plan their families, but to do it safely. And we also have to weigh the risk of, medication with the risk of bad MS flaring up, because we do want you to be able to take care of those kids once you have them. So let's talk about breastfeeding, right? So, we have gone through these transitions in society. I remember when I had my kids, breastfeeding, we know that it's very good for the baby. However, my mom did formula, and at the time that was all the rage and just as good as breastfeeding. So
Mhm.
let's talk about kind of, making the decision about breastfeeding. Is it safe to take medications while breastfeeding?
Mhm.
And then the other question that I often get is, how long can I breastfeed?
Mhm.
So what I generally kind of start with is that, we think that the activity of your disease pre-pregnancy may predict your activity post-pregnancy. So if I have somebody with really, really active MS, we may be watching them very closely and saying, all right, we need to be really considering getting back on medicine right away. But what are your thoughts about that, and how do you counsel your patients?
Yeah, yeah. I think the first thing is that fed is best, right? So
Mhm.
I think that it's important that we stay. I think people need to hear that if they don't want to breastfeed, or if they can't for whatever reason, or if they want to and can, and it just doesn't work for a particular baby or particular, parent baby duo, that's okay. Like the baby
Right.
just, the baby needs to be fed. And I think that people need to hear that. But let's say there is a plan to breastfeed.
Mhm.
Then what do we know? We know that breastfeeding is good for the mom. It long term, just in terms of general health, and it's good for the baby long term in terms of general health. It's also good for the mom specifically with respect to MS. So
Mhm.
during that period where mom is breastfeeding exclusively, so giving only breast milk, no other, supplement to the baby, during that time, there is a period where the mom is protected against relapses. Exclusive breastfeeding ends. It ends at around 6 months, and then you just can't meet the baby's growing demands, and so you have to add stuff, and then the protective effect of breastfeeding against MS goes away, but it still has beneficial effects if people want to continue. So
Mhm.
in all of that, what do we do? If a mom, delivers and has no plan to breastfeed, or had a plan but it didn't work out, then we want to get people back on their meds as soon as we can.
Mhm.
But if they want to breastfeed, then the first thing we have to do is support it, and support it, like put our care behind it. So if it's difficult, get a lactation expert, right?
Mhm.
Yeah, what do you need to do this successfully, and really give people the resources, because as common as breastfeeding is in sort of humanity and the rest of the animal world, it's not easy, and
It is
people need.
not easy
It is not
at
easy.
all.
It hurts. It's hard. It's
A
people need a
lot
lot
more
of.
sleep deprivation. Dad can't help.
It is not easy, and in a lot of Western cultures, people don't grow up just watching breastfeeding happen around them, and there's a lot of
Mhm.
taboo, and so people may not really know how to hold the baby or what to do. And so, if someone wants to breastfeed and we've decided that's the plan, then we need to support moms and babies.
Mhm.
With is the baby tongue tied? Like, what are all the pieces? So let's say we've put all of our kind of support behind the breastfeeding process and it's happening. So then we think about the safety of the meds. Like if we can, then ideally the mom would get to breastfeed and the mom would get her meds. And
Mhm.
if that's a safe piece. And so there hasn't been enough research into medication safety during breastfeeding. I have colleagues in different places who've put a ton, they've poured their hearts into this research and really generated a lot of information. I've worked on generating some information for, the B cell depleting therapies, Ocrevus,
Mhm.
Rituxan.
Mhm.
And what we see in general is it's a lot, it looks a lot better than we fear.
Right.
So there, for the self-injectable therapies and the monoclonal antibodies, there's very little drug that crosses into breast milk. And for
Mhm.
some people, that's super reassuring. And some people may want zero drug in breast milk for their baby.
Right.
So it's
Right.
still an individual decision. It's still about that shared decision-making piece. But people need evidence to make decisions. And I think we're getting the evidence. So again, I think breastfeeding is not for everyone. But if it's going to happen, people need support. And if they're going for it, then we need to think about the drug safety. And a lot more medicines than we think are reasonably safe during breastfeeding. And so, there's kind of updates happening all the time. And every few months we have new data to kind of guide that process.
Yeah.
Yeah.
That is amazing, and I'm just so grateful, for people really paying attention to this issue. And I think that a lot of it has to do with, you know, some change of the composition of neurologists, right? There are lots of women who are, doing this work to, get the breast milk and, to make sure that we're treating people as safely as possible and taking care of their MS. So that is very encouraging to hear. So we're coming close to the end. So I would encourage the audience, if you guys have any questions, please feel free to drop them in the chat. But I would like to, kind of as we round up our last thoughts, I always want to empower people, right? So what questions should people be asking their doctors about family planning? Like what are the things that you need to know, especially when we're talking about, let's say, going on medications, for a young woman who wants to have a family, let's say not this year, but maybe in the next 2 years or so. What are the questions they should be asking when they're going in to be seen?
That's so key. Is people can do some thinking about what their goals might be. And when you bring it up with your doctor, you deserve a doctor who knows some of this data. So if you find that your doctor isn't up on these things, then you deserve to get a referral, at least for a one-time consult with a doctor who is, because this is a big decision. There's a lot of pieces, and patients are making decisions for themselves, for the baby, for the family, and you deserve to have the support and information you need to make the decision. Then I think in terms of specific questions, in general, is there anything about the MS that would make getting pregnant difficult? And how to optimize, maybe stop smoking, vitamin D, exercise. What are the pieces that one could do to sort of optimize one's likelihood of getting pregnant and having a healthy pregnancy? And then in terms of specific MS care, what is the safety of the medicine during the pregnancy? What are sort of the parameters of when it should be stopped, if it should be stopped? Is this a medicine that I should go on at all if I want to get pregnant? And if you're thinking about a medicine that's going to give you a relapse, maybe you don't want to start that in the next year or two. It's not worth it. So kind of thinking about those pieces. And then I think the other piece is when you talk about, whole person care and comprehensive care, we forget that people have a lot of rehab needs, around all of the pregnancy piece, pelvic floor, physical therapy, strength, all those things. So what do we do to optimize that function before the pregnancy? And then what do we do to optimize that function after the pregnancy? So I think thinking about that proactively is really helpful. And then finally, mood is so important. It affects, relationships. It affects perception of a pregnancy. It affects the postpartum course. And so just thinking about how can we really have a person feeling as well as they can and as informed as they can going into this process will really affect things long term.
Yeah, I love that. So what I'm hearing is, number one, patients need to think about what their goals are, right? So, before you go into the doctor, it's okay to sit down with your partner, or if you're, thinking about just being a single parent, thinking about what your goals are ahead of time, right? So when you get to the office, that's not necessarily the time to plan out your life, right? So think about these things ahead of time and make sure that your doctor is knowledgeable. And if they're not, it's okay to seek a second opinion. It doesn't mean that you don't like your neurologist, doesn't mean that your neurologist isn't great. But there are some people that may have extra expertise, to at least give you another opinion. And I often have people that will come to me for a second opinion about something like family planning or counseling about specific issues. And then, I may say the same thing that their other neurologist said, and they go back to their other neurologist, which is fine. But it's okay to seek out that second opinion and get that additional information. And then, making sure that you are knowledgeable, come up to that decision-making process with your doctor. And then the other thing that I hear you saying, which is really great, and also is in line with this kind of taking care of people across the continuum of care, is making sure that we optimize your function before you get pregnant, and then also optimize your function afterwards. So, we want you in the best shape possible, mood wise, physical wise, before you have the baby. But once you have the baby, we don't throw you out with the bathwater, right? We want to make sure that you're doing okay after you have the baby, so that you can take care of the baby. And I think that those are key things, because we want people to always leave with some type of knowledge or something that they can do, or that they can talk to their family members about, or their care partners about. And so this has been amazing. This has been an amazing conversation. And we probably need to do a part 2 at some point. But, I want to thank you so much for your time. Thank you so much for all the amazing work that you do. And do you have any parting thoughts for the Brain Chat audience?
Well, thanks so much for having me today. It has been amazing chatting with you. And I think, our job as neurologists is really to support the audience in achieving their goals as much as we can. And so I think, you should go forth feeling like there's, a community of neurological care and research behind you, and, working to support your goals.
Yeah. Amazing. Well, thank you all so much for spending this Monday evening with us here on Brain Chat. And we'll see you again in 2 weeks on Monday night for our next episode. Have an amazing evening, everyone. All right.